Let's dive right into this masterclass on preventative medicine services. Today, we are cracking the code on the highly specific rules for routine exams, figuring out exactly how to navigate the infamous Modifier 25, and making sure you avoid those massive audit traps that honestly catch even the most seasoned coders completely off guard. If you want to make sure your coding is both compliant and fully optimized, well, you are in the exact right place.
So here is our roadmap for this explainer. We're going to hit the core framework, break down age tiers, tackle same-day sick visits and counseling, compare commercial to Medicare coverage, and wrap it all up with the top audit red flags. All right, Section 1. Let's get right into the Preventative Services Core Framework.
The absolute most crucial takeaway here is understanding what this encounter actually is. This is all about getting a comprehensive 10,000-foot view of a healthy, asymptomatic patient. It's a designated time for routine screenings and anticipatory guidance, not for treating an acute illness and definitely not for tackling a specific chief complaint. When a patient walks through the door purely for their annual physical, this is the exact framework we are operating in.
Now, this is a real game changer if you're used to standard EM visits. As you probably know, the 2023 AMA guideline changes simplified regular office visits to focus entirely on medical decision-making or total time spent. But for these specific preventative codes, you need to throw your time and MDM matrices right out the window. Seriously, completely ignore them. They literally do not apply here.
Moving on to Section 2, let's talk about age tiers and code selection. Since time and MDM are off the table, what actually drives your code assignment? It's strictly down to two unwavering factors. Is the patient new or established, and what is their exact age on the date of the encounter? We have 7 distinct age tiers, and they mirror each other perfectly across 2 code families. The 99380 series is your go-to for new patients, while the 99390 series is for established patients.
When you crack open the CPT guidelines, you'll see a very clear, logical progression for these new patient codes. It starts all the way down at 99381 for infants under a year old, and then it basically marches right through early childhood, adolescence, and adulthood, ending at 99387 for patients 65 and older. Honestly, your only job here is to verify the patient's status and double-check their birth date.
All right, Section 3. Same-day sick visits. This is where things get interesting.
So we all know this happens constantly. A patient comes in for a routine physical, but then they mention a sudden, severe issue, or maybe a chronic condition has dangerously flared up. We have to draw a really hard line between a standard, pure physical and a physical where an abnormality is significant enough to require the key components of a totally separate problem-oriented evaluation. Just to be clear, a trivial little problem doesn't count. The additional work absolutely must be clinically significant.
The CPT guidelines are incredibly explicit about this. If a problem requires additional work to perform the key components of a problem-oriented EM service, you go ahead and report the appropriate synchronous office visit code. But, and this is the critical part, Modifier 25 must be attached to that problem-oriented code. That modifier is what proves to the payer, hey, this was a significant, separately identifiable evaluation and management service, and it just happened to be provided on the exact same day.
Let's walk through how to actually execute this in the real world. Say a patient comes in for a routine physical, but wait, they also require significant evaluation for sudden severe abdominal pain. We're talking lab orders and medication management. You absolutely must distinctly separate the preventative elements from the problem-oriented medical decision-making right there in your chart note. Then and only then can you successfully co-build a preventative code alongside the EM code appended with Modifier 25.
Which brings us to Section 4, Preventative Counseling Interventions.
Sometimes, the entire encounter is quite literally just about counseling. We have specific codes for this, 99401 through 99404 for individual counseling, and 99411 through 99412 for groups. These are designed purely for promoting health and preventing illness in asymptomatic patients. Think of interventions for things like diet, exercise, or substance use, where the harmful behavior hasn't yet triggered an active illness. You're trying to stop the problem before it starts. Now, the manual does note that these risk factor reduction services are distinct from other E&M services that might be reported separately. But there is a massive catch when it comes to routine physicals.
And here is that catch, the bundling restriction. Because anticipatory guidance and risk factor reduction are already built right into your comprehensive preventive visits, those 99381 through 99397 codes, you simply cannot separately report these standalone counseling codes on the same day. Basically, you can't double dip. You cannot double count the time you spent talking about diet if you are already billing for a comprehensive physical. The counseling is inherently bundled.
Okay, Section 5. Let's talk about the reality of commercial versus Medicare coverage.
So while commercial payers generally accept the standard CPT, preventative age-based codes we've just been talking about, traditional Medicare is a totally different beast. It's like night and day. By law, Medicare statutory benefits actually exclude standard CPT preventative codes entirely. Meaning, if you try to bill a $99,397 to traditional Medicare, no way, it will be instantly denied.
Instead, for your traditional Medicare patients, you have to shift gears and utilize specific HCPCS codes. You'll use G0402 for the initial preventative physical exam, which most people just call the Welcome to Medicare visit. Then, for subsequent years, you move to the annual wellness visit codes, G0438 for the initial AWV and G0439 for the subsequent ones. You really have to keep in mind that encoder rules are going to flag these payer-specific policies, so you absolutely must know which payer you are dealing with before selecting a code.
And finally, Section 6. Let's look at the top audit red flags.
Make no mistake, auditors are aggressively hunting for these specific triggers. Auto-attaching a high-level problem EM code to a routine visit, massive red flag. They are looking incredibly closely for upcoding using modifier 25 without a genuinely separate and significant medical decision-making process clearly documented in the chart. And, of course, submitting CPT preventative codes to Medicare or double-counting your counseling time will trigger immediate scrutiny. The bottom line is crystal clear here. Sloppy documentation or just ignoring payer-specific edits isn't just a simple administrative oopsie or a standard denial, it is a massive compliance liability. Knowingly submitting false claims or misusing codes can actually be considered fraud and abuse. It is serious business.
So, I want to leave you with this thought. Are your chart notes an impenetrable shield protecting your practice's revenue, or are they a ticking time bomb just waiting for an auditor to notice? Take a hard look at your charts today, because mastery of these rules is exactly what separates pretty good coders from truly indispensable ones. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.